Hi, I'm Dr. Silva, and I'm going to talk to you today about Doxepin. Doxepin is a tricyclic antidepressant. It belongs to the first generation of antidepressants, along with amitriptyline, nortriptyline, protriptyline. It doesn't sound like the other ones, but imipramine, diazepamine. It is a tricyclic agent. It is so named because of its chemical structure, and it belongs to this first class, the first generation of antidepressants, if we don't include the MAOIs. The monoamine oxidase inhibitors and the tricyclic agents can sort of be considered the first class of antidepressants. And really, there are just a few monoamine oxidase inhibitors. The first antidepressant that was discovered accidentally was a monoamine oxidase inhibitor. But then the tricyclic agents were developed, and they are SNRIs, serotonin norepinephrine reuptake inhibitors. They all block the reuptake of the neurotransmitters serotonin and norepinephrine. And that leads to increased concentrations of those neurotransmitters at the synapse, the gap between neurons where those neurotransmitters are active, and increasing them decreases the symptoms of depression and anxiety. And each neurotransmitter specializes in its own set of symptoms, but for purposes of this talk, I just want to talk about Doxepin and how it differs from the other tricyclic agents. It is also an antihistamine, as are the other tricyclics, but Doxepin is the antihistamine. Among the tricyclic agents, among those antihistamines, antihistamines, Doxepin is very potently and selectively blocks the histamine type 1 receptor at even very low doses. And in fact, at those low doses, I'm talking 3 to 6 milligrams, which is the recommended dose for insomnia, it is a pure antihistamine. It has no antidepressant actions, and it doesn't cause a lot of the side effects that you see at the higher doses, including the anticholinergic side effects. Even weight gain is reportedly not seen on these very tiny doses. Cylonor was the brand name of the medication that was approved, FDA approved for the treatment of insomnia. Not trouble falling asleep, but really the maintenance of sleep. However, because it is an antihistamine and sedation is one of its side effects, it is very effective at helping induce sleep in a lot of patients. It's basically a prescription strength antihistamine, much like mirtazapine, Remeron, a tetracyclic antidepressant that has different actions on serotonin and norepinephrine. It's not a reuptake blocker, but it is also an antihistamine. And blocking those H1 receptors in prescription strength doses can be very effective. Mirtazapine is very effective hypnotic, even for people who have trouble falling asleep. And similarly, I've not used a lot of Doxepin. Well, that's not true. I've not used as much as mirtazapine, but I have found it to be useful, a lot of times in combination with other medications for the treatment of primary insomnia. For the treatment of depression, you need much higher doses. 75 to 150 milligrams is typically what people take for the treatment of major depression and for the treatment of anxiety syndromes. The maximum dose is 300, which is 100 times greater than the smallest dose that's recommended for insomnia. For insomnia, they make a 3 milligram pill and a 6 milligram pill. I don't know if they're pills or capsules, but it's 3 and 6, which is the dosing range that's recommended. So that's how the brand name was supplied, Cylonor. But for the treatment of major depression, the pills go all the way from 10 to 150, and 75 to 150 is the typical range. And that's where you see a lot of the weight gain, which is believed to be due to the antihistaminergic action, the blockade of those histamine receptors, at least in part. But you also see blockade of acetylcholine muscarinic receptors. And so you get the anticholinergic side effects as well. And those can be very, very troublesome. But Doxepin is the only tricyclic agent that's also available in a topical preparation. It's a 5% topical preparation. The only problem is you have to smear it on 4 times a day, so it's not very convenient. It's recommended for neurodermatitis and the psychodermatoses. When dermatology and psychiatry intersect, where they intersect, you see conditions in which patients have, for example, chronic itching. Maybe they had a rash, maybe they had urticaria, and the rash resolved, but the itching didn't get any better. Or they itch when they get nervous or when they get stressed out. And those patients that have a lot of dermatologic problems, psychosomatic problems that are related to stress and stress hormones, Doxepin may be your best tricyclic antidepressant anyway. If you're going to go with a tricyclic, you might really think about Doxepin because it's very strongly antihistaminergic, but also because it is available in a topical preparation. And that also might be useful for children or the elderly, people that have trouble swallowing pills, people that are not very good about that. But again, you have to do it 4 times a day if you're going to be treating mood. Side effects, well, of course, any medication can cause nausea, headaches, or dizziness. Those are very nonspecific, the usual suspects. And certainly these medication can cause it at the beginning when you're first titrating the medication. So as a person gets used to it, you do maybe want to take it with food. However, if you're taking the medication for insomnia, you need to take it on an empty stomach. Low dose Doxepin for insomnia really should not be taken within 3 hours of taking food. But other side effects include sedation. Again, that's a side effect that we exploit. We want that side effect to treat initial insomnia or to treat middle or terminal insomnia, and that's what the medication is actually FDA approved for the maintenance of sleep. And so that would be a welcome effect, but it is sedating. And so in a person who's taking it for depression, you still want to dose it at bedtime. And if for some reason you have to divide the dosage, if a person can't tolerate, say, 150 milligrams, or say they get all the way to 300 and they just can't tolerate 300 milligrams all at one time, and you have to divide the dosage and give some of it during the day, you want to give the larger portion at night because you do get sedation with it. So what might be welcome at night might be a side effect during the day. It's the same effect, but it's a side effect during waking hours and it's a welcome effect at nighttime. Weight gain is also a big issue with tricyclic agents. There's two potential mechanisms. One, blocking type 1 histamine receptors, and histamines can cause weight gain, but also the anticholinergic side effects. Blocking acetylcholine can lead to weight gain, and weight gain can be significant. You really need to measure weight at baseline and monitor it, and particularly in patients who are already overweight, patients with type 2 diabetes. You don't want to induce metabolic syndrome because of weight gain due to these medications, and that could be a deal breaker for a lot of patients. These medications also cause orthostasis. They block alpha-1 adrenergic receptors. That's esoteric, but if you stand up too quickly, you can get orthostatic hypotension, where blood pools in your lower extremities and you don't get the vasoconstriction that you're supposed to get when you have a change in pressure like that. And so you can actually get dizzy, and you can actually, in the worst case scenario, you can faint. You need to move slowly, especially if you're older, and you need to stay hydrated, well hydrated. Anticholinergic effects are varied. They include blurred vision, blurred near vision because you have impaired accommodation. You also get urinary retention, and that can be significant in patients who are older, and also if you're on multiple medications that cause that. Constipation by the same mechanism. You're also increasing norepinephrine, and norepinephrine does all of these things as well. And dry mouth is also part of that syndrome. You can also get short-term memory impairment with blocking acetylcholine, and also blocking histamine is not good for cognition either. But you get these memory problems because you are blocking acetylcholine and neurons that rely on that neurotransmitter in the hippocampus. And a lot of times it's very mild. People don't really notice it, but in the elderly and patients who already have age-related cognitive decline, for example, who are already forgetful, it can really be more prominent and problematic. Sexual dysfunction, because you're increasing both serotonin and norepinephrine. Serotonin interferes with the orgasm, lowers the libido, and norepinephrine can cause erectile dysfunction. Again, in patients that are most vulnerable, which would be middle-aged or older men. Younger men, you may not see such a problem, particularly with erectile dysfunction. And delayed orgasm isn't always a problem. These medications can actually help out with premature ejaculation, but it can really make the orgasm take a long time. It can block it entirely, and then when you do achieve it, it can be a lot less satisfying. Sexual dysfunction can be a deal breaker for a lot of patients. Sweating is another common side effect, both hot flashes as well as increased perspiration upon exertion. And I have a separate video that kind of talks about the finer points of what the difference between those two phenomena are and how they're mediated by two different neurotransmitters. But they're both side effects, and they are both can be very annoying. More serious side effects that are rare include lowering the seizure threshold, so you could theoretically get seizures. You do see seizures in overdose, and if you combine with other medications that lower the seizure threshold, for example, the painkiller tramadol, you also see prolongation of the QTc interval. That's the corrected QT interval on the EKG, and essentially that can lead to various degrees of heart block. If you already have pre-existing heart block, you could get into some pretty serious cardiac dysrhythmias, and that's also one mechanism by which these medications cause death in overdose. So Doxepin, like the other tricyclic agents, is lethal in overdose. You want to be careful giving it to patients that have suicidal ideations, and that's another controversial but potentially serious side effect. It's controversial because it's not clear that antidepressants actually cause suicidal ideations, but certainly patients can sometimes get worse before they get better. And if they're young and impulsive, the FDA has put a black box warning on practically every antidepressant for patients that are 24 years of age or younger. That may be a somewhat arbitrary cutoff. I really don't worry about suicidality. I ask all my patients about it, but I really don't worry that the medication that I'm giving is going to make someone want to take their life, particularly if that's not something that they've experienced before. And especially if you're not even taking the medication for your mood. If you're not anxious and you're not depressed and you're just taking Doxepin as a non-habit forming hypnotic agent, as a sleeping pill, there's no reason in the world to believe that 3 or 6 milligrams is going to cause you to want to kill yourself if you don't have problems with your mood to begin with. So, I really don't consider it a side effect per se. It's just something to watch for. Mania is another thing that happens very infrequently. You would again have to have an underlying predisposition to mania, in other words, bipolar disorder, and not be well stabilized in terms of your mood. And then taking a high dose of any antidepressants, and especially noradrenergic antidepressants that increase norepinephrine, that can really rev you up and can really throw you into mania, or at least trigger hypomania. But it's not something that you would see in, again, patients that are taking the medication for sleep, who don't have any mood problems, or even those patients with unipolar depression who don't otherwise get manic. Even if you overdose on it, you're not going to get, it's not a stimulant. You're not going to get mania just because you took a lot of this medicine. Unlike Adderall, anyone who takes Adderall can start talking fast and not need to sleep and get impulsive and hypersexual and all those things that we see in manic individuals, but not with antidepressants, not if you don't have that already predisposition toward that. And similarly, psychosis. You're not going to see psychosis unless you see an aberration in the mood due to taking this medication. Perhaps by virtue of being one of the older antidepressants, the FDA indications are quite idiosyncratic, quite odd, and they don't correlate with the DSM-5, the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, the latest edition of the diagnostic manual. It's FDA approved for, quote, the psychoneurotic patient with depression and or anxiety. I'm not even sure what a psychoneurotic patient is. We just don't use that terminology anymore. As well as, quote, depression and or anxiety associated with alcoholism. That's interesting. There's plenty of clinical depression and anxiety associated with alcoholism, but why should Doxepin be more effective in those patients? I'm skeptical of that. Also, quote, depression and or anxiety associated with organic disease. Does that mean as a consequence of, for example, hypothyroidism or brain trauma? That it's just so vague. There are plenty of biological etiologies for depression. If you're treating a depression that has an identified cause, like status post-stroke or heart attack, how is this tricyclic agent going to be better for those patients? These FDA indications, all it means is that the developers, the manufacturers, were able to fund enough studies and prove to the FDA that patients with these conditions got better. But we don't even use these nosologic categories anymore. Also, quote, psychotic depressive disorders with associated anxiety. That's a subset of patients. You have to have a psychotic depressive disorder with anxiety. I guess that would be major depressive disorder, severe with psychosis, with anxious distress. That's the terminology we would use now. But it's not the Doxepin molecule that's getting people better. It's the serotonin molecule and the norepinephrine molecule that are getting patients better. And in the prefrontal cortex, the dopamine molecule. It's also FDA approved, officially approved for quote unquote involutional depression. That's not even a diagnosis. As well as manic depressive disorder and Silenor, which is the low dose preparation, 3 or 6 milligrams, is FDA approved for difficulty with sleep maintenance. But it's good for all sorts of things, anxiety and depression in general, treatment-resistant depression, because it is a tricyclic. That class does seem to be a little bit better, as well as the treatment of neuropathic pain, chronic pain. Again, the class as a whole has that, and itching. That's what I have to say about Doxepin. That's kind of what makes it special and interesting, and it's probably used, I certainly use it almost exclusively as a sleeping pill when we're having difficulty with whatever other sleeping pill I'm already using and the patient can't tolerate trazodone, maybe because trazodone causes too much nasal congestion or it's just not working and we need to do something different, and we really need to try to use something that's non-habit forming. Tolerance is reportedly not seen on these lower doses, so if they work, they're probably going to continue to work indefinitely. It's not like Ambien or some of the other sleeping pills where you start taking it and after a while you develop tolerance to the sedative effect. I do have another video though on how you should take sleeping pills and how you can make your sleeping pill keep working, because you're going to develop tolerance to sedation, but that doesn't mean that the pill needs to stop working. And that's another topic. Thanks for listening.